I have to admit, I didn't know what a TED Talk was. I really thought it had something to do with the movie Ted, you know, the Seth MacFarlane movie about the cute little talking teddy bear, and basically all he does is curse and smoke weed throughout the whole movie. I didn't think it was about that, but I don't know if what I put together is a TED Talk or not, so you guys will be the judge. I am talking about the payer perspective today. I am Vice President of Dental Programs at AmeriHealth Caritas. We have Medicaid programs right now across the state, except in the Southwest Zone, and that's pending as well. So I wanted to I just wanted to give a very basic overview. And again, I come to you from the perspective of a Medicaid managed care plan. That is the prism through which I speak. So I just wanted to give a basic overview for those who didn't know about how care is delivered. And I'll just go through this very quickly. All care is provided within contracted networks. That's very, very basic. All provider groups, we contract at the group level, not every provider, and not every participating provider. However, every provider must be credentialed. So that's a basic. Networks are open networks. We don't have any assignment of members, no attribution of members. They're open networks. Our members are free to go to any dentist they want. There is no gatekeeper of any kind. Members are able to access referrals as they wish. There are no specialists, I should say. There are no referrals required. So that's just a basic overview of how care is delivered. Basic goals of our program, and I guess the most significant goal is for us to be able to provide sufficient access to care. So we as managed care organizations are measured by our access. There's a standard called GEO access, which we need to be adhered to. The state mandates this, DHS mandates this, and basically for different provider types and in different areas, basically the differentiation is rural versus urban. In most cases, that differentiation is by county. In some county, there are both rural and urban standards. So the basic for general dentists, and there are a number of different categorizations. For general dentists, the standard is in urban areas, there need to be 2 providers accepting new patients within travel time of 30 minutes. And then for rural areas, with the understanding that people generally used to traveling more and there is less access to care in the rural areas, 2 providers accepting, again, this is for general dentists, 2 providers accepting new patients within a travel time of 60 minutes. We obviously aspire in terms of general goals of our program. We aspire for high quality. We aspire to be cost effective, as we all need to do as stewards of public funds. And for us as a Medicaid, primarily a Medicaid-focused organization, we do have some Medicare as well, but our focus is on children and it's on preventive care. I would say estimated our members in the Medicaid side, as with any Medicaid program, approximately 2/3 of our members are under 21. And that's the differentiation for us between children and adults. So what are some of the access challenges that we face? First of all, GEO access really doesn't provide much information about what goes on at that provider's site. GEO access is literally a dot on a map, so it doesn't differentiate from a small office that might be open 2 days a week with 1 chair and the dentist has no auxiliaries to a large multi-specialty practice. There's no differentiation. Generally, as a general rule, there is less access available in rural areas. Certainly from a specialty perspective, we know, and we've heard this, a lot of this is redundant based on conversations we've already had. Specialty care is a real problem, much less access to specialty care in the rural areas. And from a Medicaid perspective, that's even more exacerbated. I know there have been some statistics that have been shown about the number of the total access. I believe personally that might be a little bit overstated. Restrictions on care delivery. As I said before, not all the practices can provide the gamut of care to make them most effective for our members. There might be, especially in for some of the smaller practices that we see, limitations on hours, limitations on accepting children, age limitations that are in some cases above 5, above 3, really missing the neediest of our children, and also limitations in the amount of specialty care that can be delivered. Also creates problems for us. One of the things that we're facing, and I'm surprised it hasn't been brought up yet, that and I guess it's going to be the first time we hear about this, that the managed care organizations in Pennsylvania are now going to be getting into the area of what we call LTSS, long-term supports and services. This was really the last province, I would say, of the state of the fee-for-service program having 3 minutes, right? Having direct care. So this is now gravitating to the MCO. So we are now, the managed care organizations, the Medicaid organizations, are now going to be responsible for providing care to a totally different segment of the population. LTSS members are typically dual eligible. They are typically in many, many cases, they have more chronic health issues. In many cases, they live in long-term care facilities of some sorts. In many cases, they live at home. So it's going to be an additional challenge for us to provide the care in those settings. And finally, just as an administrative burden for providers, again, all the providers have to be credentialed. There's the need in Pennsylvania to have both an MAID number, a promise number, and to be credentialed individually by all the plans. It is burdensome, and it would be great if we could come up with a solution to that. So in terms of innovation, and I guess this is the core of what I was supposed to speak about, I think we need to speak a little more qualitatively than quantitatively, under the assumption that at least from a dental office perspective, there is going to be a finite amount, at least at this point, of utilization. So what do we do to enhance the utilization and enhance the capacity that's already in place? One of the things I've spoken about for a long time, is to have an assignment model, a primary care dental model similar to what we see on the medical side. For the life of me, I don't know why it's not done more. It creates so many advantages. Now, we talk about sort of conceptually the fact that dentistry trails the medical side by however many years. For the longest period, patients, members access health care at primary care physicians. I can't even think of scenarios, although there are some more open networks, but for the most part, there are primary care physicians. I have 1 minute left. I'm going to run over by a minute or two. So I think from a qualitative perspective, it will behoove us to think about having an assignment model where members are assigned. No, we don't want to do, they choose and then they're ultimately assigned based on certain algorithms. We certainly don't want to do this as a potential barrier to care. And certainly there's not going to be any limitation on people when they go to a dentist to change dentists. But I think from a continuity of care perspective, from an educational perspective, and an alignment of incentive perspective, I think it's something we're going to actively pursue. We have this in D.C. We have a program in D.C. We inherited it's called a PDP, whatever that stands for, but it's an assignment model. And what we've done, we spent a lot of time to make sure the attribution of members, the assignment of members is correct. And we've a lot of education around this. And coming off of this, and it gets into some of the other things I want to talk about, in terms of opportunities, creating alternative compensation arrangements, risk-based arrangements of different types, quality-based arrangements, and then we've heard a lot about value-based contracting. So an example of value-based contracting, right now all the compensation transactions are based on volume. And there's a move, again, more so on the medical side than what we see in the dental industry, a move away from that to looking at paying for outcomes, at paying for quality. So in D.C., again, I can cite a specific example. Because we have the assignment of members to primary care dentists, we are developing a value-based model. We've developed it already, and we'll be rolling it out probably the first quarter of 2017. So it's an additional bucket of funds that the dentist can have. Again, because there's an assignment of members, we can have specific rates. We call it a denominator, the specific number of members on the bottom line. And on the top line, we want to be able to measure for certain metrics how many of those members get care. So simplistically, we look at just total access, how many members get care. That's one of the HEDIS metrics that we use. And it's a very, very important metric for us as a plan on a comparative basis. In Pennsylvania, it also relates to P for P. I have a lot to say. P for P money that we get from the state is a very important metric. But for our model in D.C. and the template we put together, we're for the first time having dentists look at metrics on the physical health side. We're assessing where the interplays are, where the clinical interfaces. And certainly we know there are substantial clinical interfaces with diabetes, with asthma. Oral cancer is a huge public health problem. The HPV vaccine, we want the dentist to take a look at that. So we're going to provide the dentist, the primary care dentist, with clinical information on the physical health side. For them to be able to encourage their members and guide their members within the context of a dental conversation. And we think that from an overall quality perspective, it will improve rates. We're also looking at the dental quality metrics, the DQA. An arm of the American Dental Association has 5 metrics that are become sort of the standard for quality. Certainly the HEDIS, the annual dental visit HEDIS rate, very important metric for us. And then also to look at potential cost savings. You know, we always want to have the opportunity to allocate funds, our finite funds that we get from our governmental partners, allocate them in the most productive way. And certainly when we look at some of the waste within the system with non-emergent dental ER, with the amount of OR use that we see, you know, we love there to be able to be some abatement around that these primary care dentists will take the lead on, and we will compensate them for that. So I'm really excited about that. I think that model is something that's innovative. It's something that addresses integration, which is something we aspire to, and it really gets the dentist hopefully to be thinking in a different way. So if we can do it in DC, I don't see a reason why we can't do it here. It's you know, everything is a little complicated and it takes time, but we actually have this in place and we're moving forward with that. And the other big opportunity we have is with PHDHPs. So we have this, and especially in the context of LTSS, we need to be able to provide more preventive care in facilities and in people's homes. We don't know where that's going to come from necessarily. We want it to be quality care. You know, I think the PHDHPs, because of the ability to have different settings of service that really match what the needs are going to be around LTSS, would really be the perfect solution. You know, it's going to take some innovation to get there, maybe new business models, but I think we lose an opportunity when we don't do more with the PHDHPs. So I could go on, but I'm at least 5 minutes over, so I thank everybody for listening.